All right, welcome back, everyone. We'll move on to the next presentation. This is going to be focused on the biology and clinical aspects of disparities in multiple myeloma. It's going to be a joint presentation. Dr. Ajay Nooka and Dr. Larry Boyce are going to give this. Dr. Ajay Nooka is Associate Professor in the Department of Hematology and Medical Oncology at Emory. He serves as the Medical Director of the Winship Research Informatics Shared Resource. Dr. Boyce is the Randall Rollins Chair in Oncology. He serves as the Vice Chair for Basic Research in the Department of Hematology and Medical Oncology, and he's also the Associate Director for Education and Training at Winship. So let me turn it over to Ajay and Larry.
Thanks, Ram. Thanks for inviting to the Winship Scientific Symposium. I'm honored to co-present this talk with a guide, friend, and a mentor, Dr. Larry Boyce. So we'll be talking more about the biology and the clinical aspects of disparities in myeloma. Here are disclosures. So in 2020, of the 1.8 million cases of cancer diagnosed in the United States, 32,000 are diagnosed with myeloma. We see close to 13,000 deaths from myeloma, and Georgia gets more than a fair share of its myeloma burden, with 1,100 Georgians diagnosed with myeloma in 2020. We'll have 420 deaths from myeloma. And one fortunate thing with Georgians diagnosed with myeloma is more than half of them get an access to a myeloma specialist and receive the state-of-the-art modern care for myeloma patients. So here is the graph or the map looking at the incidence rates over a 5-year period and the death rates to the right. What you see in terms of the gradation of the color, so the lighter to darker intensity represents the lower to the higher rates. To the left is the incidence rate. If you pay close attention, we're one of the 4 states with the highest incidence rates of multiple myeloma. If you compare them to the right, you see we're a tad lighter, which potentially represents either we are treating a completely different, biologically different patient population, or we're doing something right from a therapeutic perspective in terms of giving them the right treatment options. To take you through what the disease continuum process of myeloma looks like. Myeloma is a disease that has a precursor state of a monoclonal gammopathy of undetermined significance and a smoldering multiple myeloma. Historically, myeloma is defined by having an end organ damage related to a clonal process as described by the CRAB criteria: high calcium levels, renal failure, anemia, bone lesions. And more recently, in the last 5 to 6 years, we have a biomarker-driven diagnostic criteria that included 60% plasma cells in the bone marrow, serum free light chain ratio of greater than 100, and the involved serum free light chains of greater than 100 milligram per liter, or more than 1 focal lesion by the MRI. Myeloma serves as a perfect example of a disease prototype through the continuum process, studied with biological, clinical, and therapeutic disparities. Madhav Dodapkar from our group led the cooperative group trial from the SWOG, showing race-dependent differences in the risk of transformation to clinical myeloma. Of the 331 patients with the precursor states enrolled on this SWOG trial, which is a prospective observational trial, over an 8-year period, the enrollment happened between 2003 to 2011. 17% of the cohort were African American, and Madhav was able to show the transformation to myeloma in African Americans was significantly lower than in the non-African Americans. The 2-year risk of transformation was 5% in the African Americans compared to 15% in the other races, and the 5-year estimates were 13% versus 24%. So the proportion of the patients with the high-risk gene expression profile gene risk score was lower in the African Americans compared to the non-African Americans. And these are predominantly driven by the chromosome 1 abnormality, which previously have been implicated in the progression from MGUS to the precursor states. Interestingly, the African American cohorts were very young compared to the non-African American cohorts and had higher rates of EBV exposures compared to the non-African American cohorts. The SWOG group hypothesized that earlier exposure to EBV in African Americans due to various factors, due to various social and economic factors, may expose the African American patients to greater cumulative risk of chronic B-cell dysregulation, leading to earlier or higher risk of MGUS. So coming to what we look at the symptomatic myeloma perspective, so the incidence risk of multiple myeloma in the African Americans is 2 times higher than the Caucasians. And if you take specifically for the African American males have a 4 times higher incidence rate compared to a Caucasian female. So there's a huge amount of disparity that exists biologically. And Nisha, one of our junior faculty members, presented our experience with 1,000 patients treated with RVD induction treatment, which is including lenalidomide, bortezomib, dexamethasone. And she assessed the differences in the presentation, the disease biology, and the outcomes in African American patients. As you can see, 35% of our cohort was Black, and this is consistent with the demographic representation of the state of Georgia, as well as the institutional referral patient population. Relative to the Caucasians, Blacks were 5 years younger. So median age for African Americans was 57 years old compared to 62-year-old for the Caucasians. Blacks were more anemic at presentation and had lesser rates of high-risk presentation. That means if you look at the spectrum of myeloma, it includes the high-risk patients, which included around 15% of all myeloma patients, and standard risk patients account for all the other 85%. And if you specifically look at these 15% of these high-risk patients, you see lesser number of African Americans. So now, if you, in a sense, like you're literally saying that Blacks have more favorable disease, but if you look at this cohort, we see exactly the same PFS benefit, both from for the African Americans as well as the whites. No differences for the PFS by the race was seen. So one can conclude, when offered the same induction regimen and the access for stem cell transplant, African Americans had similar survival benefits compared to the white counterparts. Now, if you look at the survival of the entire cohort, including the standard risk and the high-risk patients, is beyond the 10-year mark. The lack of significant difference in the PFS or the overall survival suggests that we have standardized the aspect of the access to care, and these could lead to long-term outcomes. However, one should expect much favorable outcomes in a population that has less aggressive disease, and there could be a biological reasoning for this. And here comes the slide for Dr. Boise.
Yes, so thank you, Ajay. And so we've been interested in this idea that we have these African American patients who apparently have a disease that looks like it should be lower risk, but they're not, and given the same induction therapy are doing the same. One would think that they might do better. So we decided we would look genomically at African American patients versus patients of European ancestry or Caucasian patients. We did this using the COMPASS study from the Multiple Myeloma Research Foundation, where it's a sequencing study of over 1,000 patients that are being followed over 8 years. So we have outcomes from these patients. And this is looking at the whole genome sequencing of 536 Caucasian and 114 African American patients. And what one can see is that if we look at the translocations that are associated with normally with the initiation of myeloma, about half the patients, those are the ones shown in red. So these are IGH translocations. So juxtaposing the strong enhancer from the immunoglobulin region to MAF or NSD2 or WHSC1 and cyclin D. that there's really no difference both in the clonality shown in red as well as the frequency shown by the thickness of the line. However, if you look at the other types of translocations that we observe in myeloma, we do see differences. And I want you to focus primarily on two of them. These are all, again, as shown here, frequency of greater than 1%. And so the first one I will point to are the MYC translocations, which data at the bottom of the circus plot. And you can see that that MYC goes all over the genome for activation. It's the most commonly translocated gene in myeloma. And you can see that it goes to many different potential enhancer regions in African Americans compared to patients to Caucasian patients. This turns out to be important because one of the findings that Ben Barwick published last year was that where MYC is translocated actually has an effect on its function and its ability or its role in survival of myeloma patients. And so if you could hit click one time for me, Ajay. And in fact, the place where he found that there was a real difference with MYC, even though the levels of MYC expression were not really different, was the translocation to chromosome 22, or the lambda locus, or the light chain lambda locus of immunoglobulin. And you can see that the numbers, actually, the frequency is not that different in MYC IGL translocations here. It's slightly higher in the African American group. There is a difference in the IGH MYC translocations, where there is really none in the African American group. But these patients who have IGL MYC translocations, or IGL translocations in general, actually do poor in this COMPASS data set, is what Ben published last year. So we've now gone back and looked and broke this up based on race. And what you can see, if you can click one more time, is that within this group, there's a profound difference in the survival. So the top is we're looking at the overall survival of patients who had any IGL translocation, with the grayer line being patients of European ancestry, and the darker line being patients of African American ancestry. And you can see there's a significant difference. And it's really, even though the patient numbers get somewhat small, but if you break it down to the IGL MYC translocations, there's even a further difference in the survival of these patients, almost to the point where it looks like most of the survival, real high-risk patients that we're seeing with these are in fact the African American patients. And so this is something that we're now pursuing actually in our own patient population. So, Ajay.
This serves as a perfect segue for talking about the differential therapeutic responses by the race. So GRIFFIN trial is a randomized phase 2 trial that has looked at addition of daratumumab for achieving a deeper response for a primary endpoint of stringent complete response compared to the standard of care, the 3-drug regimen with Revlimid, Velcade, and dexamethasone. So the primary endpoint is post-consolidation after 6 cycles, achieving a stringent complete response. So the study not only met the primary endpoint, which was reported in 44% of the patients achieving a stringent complete response among patients that received the daratumumab, compared to 32% among the patients that received an RVD. It has also showed that the MRD-negativity rate significantly deepened. At the end of consolidation, 44% of the patients achieved an MRD-negativity at the threshold of 10 to the power of -5, which means the ability to detect one myeloma cell in 100,000 cells. So MRD-negativity at the rate of 10 to the power of -5 is 44% among the daratumumab arm versus 14.6%. So this study has enrolled most of the patients at Emory, and majority of the patients that we enrolled were African American, which led to our observation of a potential therapeutic effect by the race. And we reached out to the sponsor to specifically look at the responses by the race. So we were surprised to see the responses for the control arm of RVD are almost exactly alike between both the Black patients and the white patients. And if you recall back to the data published by Nisha for the 1,000 patients, this is almost exactly a meta reflection of what our internal data set looks like. Nevertheless, the difference that you see with combination of daratumumab showed that in the purple bars resulted in a higher rates of stringent complete response in both the Black patients as well as the white patients. Now, the relative benefit that you see in the Black patients is significantly higher compared to the white patients. So now this has led us to go for a specific LOI for the Stand Up to Cancer grant, enriching Black patients for the clinical trial with daratumumab and RVD combination. And we recently got invited to submit the full proposal with Colleen McBride leading the efforts. So this is a combination grant with UAB and Moffitt.
So also along those lines and looking at therapy, one of the areas that we've been interested in lab, particularly Vikas Gupta and Shannon Matulis, is looking at the response to venetoclax, a BCL2 inhibitor. And what's known in myeloma is that patients who have the T1114 translocation seem to respond to this. And we've actually gone back through and we noticed in our ex vivo studies that are actually very predictive of patient responses, that they're the African American 1114 positive patients, that almost all of the samples were sensitive. So we went through our patient population, and I think this is actually reflective of some of the things that were discussed by Dr. Brawley and Dr. Carthon about the not being powered to actually do some of these types of analysis. But what we found was that, in fact, that we had, in fact, almost of these 7 African-American patients, 1114 that we had, 6 of them responded. The other one actually had stable disease. So there was a clinical benefit in all 7 patients. This is different than what we see in the Caucasian patients. And so if you look at the overall response rate, they're not that different in these venetoclax containing regimens, but the quality of their response appears to be greater in the African Americans. And so to really test this, Doctors Jonathan Kaufman and Vikas Gupta are currently preparing an application for the FDA to do a study where we can begin to look at differences in response as well as safety for venetoclax in this patient population.
As you've clearly seen, heard before from various presentations about the myeloma clinical trial enrollments, we had been enrolling close to 35% of all our myeloma clinical trial enrollment to be minorities. This is a clear reflection of the demographic of our state and that of our clinics. And for a disease that has 20% of patients that are Black, the clinical trial enrollment across all trials that enroll the drugs that have been approved so far by the FDA, only 4.5% account for African Americans. So we've been a vanguard in this area of minority accruals and serve as example for other institutions. And clearly, as you can see, for the most of last decade, we've consistently enrolled a very large fraction of minorities in our clinical trials, bringing access to the new drugs. Our team on the right, which needs no introduction, and we hold the disparity aspect of myeloma very near and dear to us, and are constantly working to understand the differential biology and aiming for the health equity by improving science. And thanks to Dr. Boise and Dr. Dodopker for spearheading this aspect. Stop here and take questions.